Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
We'll be talking about using HIV-ASSIST to guide ART decision-making. And really the key part of the title is guiding, not meant to sort of be the end-all be-all, but really how can we use HIV-ASSIST to kind of enrich our decision-making rather than replace our decision-making or use it only for the decision-making. I have no conflicts of interest or relationships to disclose that are financial or anything like that. As far as disclosures go, I first heard about HIV-ASSIST when I was a ID fellow. I helped with some of the validation, and we'll talk about the study in which I participated. And then I do serve on the scientific advisory board, which means that if they have questions about certain ART management things, I give my opinion. And I have no disclosures from anybody else. So I thought we'd talk about what is the HIV-ASSIST decision support tool, and then talk about use of HIV-ASSIST in different clinical scenarios or in different use cases, as Brian has mentioned. So a little bit of background. So what is it? It's a website, and it's a free online evidence-based decision support tool for ART selection. Again, I really like the fact that it says decision support. It was developed by ID experts at Johns Hopkins, and it uses something called multiple criteria decision analysis theory, which I had to look up, and is basically, as it sounds, it's this sort of theory and psychology and math about how do people make decisions when there's lots of criteria involved. And it's evidence and guideline based, and it uses evidence and guideline based effectiveness of ART to rank different ART combinations. It incorporates viral attributes, patient characteristics and preference, comorbidities, and co-medications. And the algorithm, which I can't speak much to beyond the fact that there's saying that there's an algorithm, draws from the DHHS and IAS USA guidelines, from clinical trials, from the Stanford Resistance Database. It actually links it directly in with that, the National HIV Curriculum, the Liverpool HIV Drug Interaction Checker, and this scientific advisory panel, which I mentioned earlier. This is what it looks like. So when you go to the website, here is the sort of link. It looks like this. And you start by clicking on Start Now to enter. And then it gives you something that looks like this page, which is really the area where you would input the data. And I'm going to go through each of these sections just so you have an idea and get comfortable with using HIV-ASSIST if you so wish to use it. So first off, you can incorporate any mutations the patient may have. Usually I do, here it says that you can enter the mutations here with or without the mutated amino acid, but I usually do input the amino acids. You have to use it in uppercase, and then you can separate mutations with a comma. Then, for patients with poor adherence, you can state if the patient has pill aversion or might prioritize smaller pills, patients who prefer once daily dosing, or if they have intermittent adherence, or if you would like to include prioritization or increase prioritization of at least 3 drugs. And then to penalize regimens with IV or IM dosing, which I would say a lot of people might want to do that. Then you kind of put in some more patient characteristics, viral load, CD4 cell count, HLA-B5701. Typically it defaults to positive or unknown because a lot of the time we don't know it. For the purposes of these examples, I've clicked negative just so you can see it, but typically it will default to positive or unknown. And then the tropism. Then you can put in comorbidities, any ARV side effects that the patient has had, i.e., let's say they had nausea from protease inhibitors, you can put that in here, or pregnancy. And then co-medications, treatment history, and their current regimen. One thing is that you can put in as little or as much information as you like, so don't feel beholden to typing everything in, though your outputs may change accordingly. And the other thing that I would like to mention about the co-medications is that one of the things that they're working on is that Liverpool is now going to directly interface with HIV-ASSIST so that you can get that information without having to go somewhere else. If you scroll down on the page, it will then sort of show you what it excludes. Notably, it excludes a lot of the older ART. Interestingly, it excludes TDF, and I feel pretty comfortable using TDF. So a lot of the times I uncheck this, and I actually was going to write to the developers and say hey, especially nowadays, we're learning that TAF isn't without any side effects. And, we may be seeing more weight gain in the state of Washington. It's not on the Medicaid formulary. And so I just wanted to alert them that maybe they should unclick that. You can put in your preferred regimen or what you're thinking about. I oftentimes don't do it, but that is something where you will get direct feedback on where your ART decision may fall on their sort of, again, computer algorithm. And then you press submit. And then this is what it looks like. So basically, this is the page you get. As up here, it sort of tells you the inputs. It reminds you of the inputs that you put in. Again, this patient has none of these, CD4 count greater than 200, viral load is high, etc. So this would be kind of what do you do for a new start. And here you'll see that the top ART regimens that they suggest are BIC/TAF FTC, dolutegravir abacavir 3TC, dolutegravir and TAF FTC, or dolutegravir 3TC. And if that looks familiar, that's because it is, because those are the DHHS recommended some of the drugs for starting most people with HIV on ART. We'll give you this weighted score. We'll tell you the number of active drugs in that regimen, the number of pills per day, and then the frequency per day. And it takes those things into account by getting the weighted score. And I'll talk a little bit more about the weighted score as best as I can. When you click on instructions, you can get a little bit more information. And this is what I wanted to show you, is if you click on that, it'll tell you how does a score come to be. If the score is in green, that typically means that the score is less than 1.5 and there's strong evidence for efficacy and strong evidence for tolerability. And then as you can see, the colors become more like a stop sign, where the green fades away to yellow, orange, and red, where there's poor evidence for that. If you have questions about how the algorithm exactly works, please feel free to go to their website. There's also a clinical care option where they talked about this. And I am not a mathematician or a computer scientist and can't go into much detail about that. However, I do want to mention that this composite score, again, takes into account efficacy and tolerability. And if you're wondering, hey, how did they score this? And I'll show you what it looks like. Click on the scale so you can see how it's penalized. That it doesn't mean that you have to follow how they score something, but it at least gives you some food for thought on how to think about the ART that you're choosing. Now, back to the same screen we saw before. Again, these are the four options that have the lowest weighted score. And I wanted to mention that if you double click on any regimen, that will give you an educational sheet. So if you click on BIC/TAF FTC, it will tell you some information about this. This draws, again, from the DHHS and IAS USA guidelines and from the National HIV curriculum. If this takes you to a new page, and on that page, if you scroll down, there's a lot of paragraph form information, but then there's a table that shows you all the trials sort of comparing treatment-naive dolutegravir or bictegravir use in individuals. Back to this education sheet. So what I just showed you was from the info sheet. Next, it tells you dosing info about how to take it. Here it says there's a food effect and administration interaction. So if there's something for you to be aware of, there's a red exclamation mark. And then again, here you'll see that it's drawing from the National HIV curriculum. And then if you want to know about the rationale, it'll tell you how the math or the computer science kind of worked about this. And so here it says that all regimens with more than one pill once per day incur a pill burden penalty. And again, some of us use more than one pill a day, but that's just something that they have prioritized in the algorithm. And then you may ask, does this actually work? And so when they first started this, it was really started from a group of individuals, Johns Hopkins. It was Manoj Madali and Manang Shah. They developed the tool and validated the tool. And so this first validation was where they had a cohort of 17 experienced providers and had them review 10 hypothetical cases. So they looked at those hypothetical cases and said what they would recommend. When they compared that to HIV-ASSIST, there was 99% concordance for ARV-naive patient cases. How did they define concordance? That meant that if the provider picked anything that was in the top 5 suggested regimens from HIV-ASSIST, that was concordance. And then they found that there was 84 to 88% concordance for ART-experienced patient cases. That's not exactly surprising that there's a lot more variability and there's a lot more gray when it comes to making decisions for people who have ART experience. Then what they did is that they wanted to evaluate the concordance of the tool, looking at real patients and not just hypothetical cases. So they did a retrospective chart review of 106 patients at 2 clinics, and this is what I participated in, just the chart review. And so they found that there was 100% concordance for ART-naive patients and 88 to 89% concordance for ART-experienced patients. I thought this was helpful as someone who was going through the chart review and actually reviewing some people that were on my patient panel and sort of recognizing, oh, this person's on a regimen that's a little outdated and maybe I should think about this. And then seeing kind of how far lowly the person on Genvoya scored, for example, because they were on cobicistat, and they really penalized those drug-drug interactions. And it did lead me to make some changes. And the way it really made me sort of make some changes was that oftentimes when patients come in with HIV, they have many other problems that we're addressing. So I was focusing on the COPD and the hypertension and the hyperlipidemia, and kind of just for people who are really stable, I wasn't really taking much account into the ART, but or at least not always. And so this sort of just running an ART check was helpful in that I could make sure that they were on a regimen that wasn't super outdated and that might be more in line with current guidelines. I am just seeing some of the questions here that it says that Dave Hadji mentioned that you noticed the recommendations for tenofovir including only TAF. I mentioned that I think it was because they were concerned about the renal issues, and I'm going to give them feedback that I think they should unclick that. And then I see that Anushka asked if the tool is linked to the Stanford mutation database and the Liverpool drug interaction checker, which is true. Yes, it pulls directly from that. And then lastly, as far as HIV-ASSIST in the literature, they wanted to look at how it was to use HIV-ASSIST versus the DHHS guidelines. So they actually did a randomized study of 118 medical trainees at Hopkins who were given the HIV-ASSIST tool or DHHS guidelines to select ART for 10 hypothetical patient care scenarios. So these are trainees who are not HIV-specific providers, and they said, here are some cases, try and make an ART regimen for this person. And they found that appropriate ART selections were made 40% of the time with the guidelines versus 90% of the time using HIV-ASSIST. So it can be also useful as a learning tool for early learners in HIV. So that's a little bit about the background. And then I wanted to go through what it's like using HIV-ASSIST in different clinical scenarios so you can just get a sense of what it looks like, what's some of the information that you're getting. Again, we've already talked about this a little bit, but what about ART start in a newly diagnosed person with HIV? In this case, it's a 26-year-old man. His CD4 cell count is 360, and his HIV viral load is 34,000 copies per milliliter. And so here I have inputted that he has a viral load that is 34,000, has a CD4 count greater than 360. Again, for the purposes of this, I wanted to pretend that this person is HLA-B5701 negative, and we don't know his profile. And then here, again, this is the output for ART start in a newly diagnosed patient. I wanted to mention again that these are the top 4 regimens, recognizing that TDF is not included, again, because I didn't unclick it for the purposes of this talk, but that these are the recommendations based on the DHHS and IAS USA guidelines. If you had clicked that the HLA-B5701 was unknown or positive, this abacavir containing regimen would fall very far below. Now, what if the patient has pill aversion? And so if the patient says, I can't take a big pill, then you can click this, and then it'll show you here, and I wanted to highlight how it changes the sort of order, where TAF FTC and dolutegravir becomes the sort of highest ranking, and then the Triumeq gets demoted because it's so large. And notably, both Descovy and dolutegravir are smaller than Biktarvy, and that's why it is up here, again, prioritized, and despite the fact that there's 2 pills. So it took that into account. Then what if the patient had a baseline viral load greater than 500,000? So then you, again, click that here for viral load, and then it will actually remove dolutegravir in 3TC or from this recommendation. And as a reminder, the DHHS guidelines say to not use in individuals who had a viral load greater than 500,000 because that was not part of the main trials that helped get that FDA approved, or at least had a very low amount of individuals in that viral load range. So that's how that takes that into account. What if the person starting ART is pregnant? So a 22-year-old woman is pregnant. I specifically said that she's 16 weeks gestation and receives a positive screening HIV test when she is establishing prenatal care. And here I've just put in the information as before. And we actually, this person has just shown up, so we don't actually know the viral load, CD4 cell count. I keep clicking HLA-B5701 is negative, again for teaching purposes, and the tropism is unknown, but I clicked that this pregnant person was pregnant. And so here it says, these are the recommendations based on that. I put 16 weeks here so that it showed us that you could use TAF FTC in addition to TDF FTC. A reminder there being based on the impact data is that we have some data that suggests you can use TAF in pregnancy, but that study was only really looking at people who enrolled during the 2nd trimester and beyond. What if the person has an M184V mutation? You put this mutation in here, and let's say that this person's on Genvoya and are currently on this and are failing it. It will then give you recommendations like this. Some of these I also have a little bit of feedback, so I'm going to give them feedback about the algorithm based on some of their recommendations. And you all should feel empowered to write and say, hey, I think that this could be improved, or this, I'm doing something differently. And they will actually, Manak Shah will look at it and will make adjustments accordingly. So it is very receptive to change, and they also try to work on staying up to date. The M184V, there's a lot of stuff changing with that of late, and so I do think that they need to work on that. What if the person has multi-drug resistant HIV? Here are many mutations. I inputted them there. And then you can notice that when someone has this much drug resistance, there's no green. It's all kind of like light green, yellow. These are tough decisions to be making. There's also a button you can click that says, please like to send your case. You guys usually send your cases to this group, and so you guys all discuss here, but for people who don't have access to an ECHO community, they can send cases that they need a little bit of help with. Or they also say, please call the National Clinician Care Consultation Center for help. I think Anushka had asked a question about Stanford. I forgot to include this, but if you click on report, I believe, it takes a photo from Stanford based on these mutations and tells you all the penalties. So you actually don't have to click in something else. This will do the Stanford for you. What if the person has comorbidities? Let's say this is a 56-year-old man with coronary artery disease and HIV, whose last CD4 count was 560 and viral load was undetectable, who's on abacavir 3TC and dolutegravir or Triamec. We put that in here, state that he has coronary artery disease and that he's on Triamec. And because of the association between Triamec and heart disease, or between abacavir and heart disease, that has gotten deprioritized on this. And so you'll see down here, farther down in the light green, is the current regimen that the patient's on. And it gives you that feedback about what was your preferred regimen or what's the current regimen. And it will tell you, again, please do look at and see how people get penalized, that here it says, this regimen incurred a penalty due to use of abacavir in coronary artery disease. And then what about drug-drug interactions? I put in that a patient was on warfarin and on a cobicistat-containing regimen with Genvoya, and here you will see that the current regimen that they're on is suboptimal, or based on that, and so gets really deprioritized. So that was a whirlwind introduction to HIV-ASSIST, and I find that it's a helpful tool to aid in ART decision support. That again, you can input as little or as much information as you would like, that the information comes from many different resources, and that there's a group of HIV and ID experts who keep the tool up to date. And there are several new functionalities on the way, including the liver pool, that it's going to pull directly from Liverpool and give you that information, that they're working on an app, and then I believe there's a new LTBI and ART module if you are having to treat LTBI and make those decisions.
Thank you for watching this edition of the Mountain West AETC Project ECHO Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.